Welcome back, everyone. Dr. Cohen, Dr. Oliver, are we ready?
We are ready.
Very good. A comment for the general audience. As you can see, we're doing our questions and comments section a little different today. I want to make sure that everyone feels they have an opportunity to be heard and that we proceed along a line of commentary without interrupting it and going back and having a disjointed discussion. So if anyone feels that this is not working, send me a quick text on the chat and we can see if we can work it out better. Overall, I've heard that it seems to be working okay. So without further delay, let's move on to, again, another topic by Dr. Oliver, the EtR framework, this time dealing with values, acceptability, and feasibility domains. Dr. Oliver, it's all yours.
Thank you so much. Next slide. So in this presentation, we'll be discussing the EtR for values, acceptability, and feasibility, again acknowledging that all of these domains will be impacted by individual vaccine characteristics. Next slide. So first for values. Next slide. One of the questions for this domain is, does the target population feel that the desirable effects are large relative to the undesirable effects? With additional questions for, how does the target population view the balance of desirable versus undesirable effects? And would patients feel that the benefits outweighs the harms and burden? And does the population appreciate and value COVID vaccine X? Next slide. There's also a second question for the values domain. Is there important uncertainty about or variability in how much people value the main outcomes? Next slide. For this domain, we conducted a review of the scientific literature, focusing on vaccine intent, confidence, and attitude with the search terms listed here. This included scientific articles, as well as news media and reports, and preliminary findings from CDC work, including a vaccine intent survey and focus group discussions. Next slide. The overall acceptability of a COVID vaccine was moderate. The proportion intending to receive the COVID vaccine ranged from 40 to 80%. Nearly all of these surveys were performed prior to news for any specific vaccine. However, one survey was conducted after Pfizer's efficacy announcement, where a large proportion believed that the vaccine would be safe and effective. Many surveys reported anticipated benefits to vaccination to protect self, family, and community, prevent infection and severe illness, and return to normal life. Vaccine intentions varied by time, population, and vaccine characteristics, with a decline from May to September. Acceptance was lowest among Black respondents and highest among Asian respondents. Acceptance was greater with higher socioeconomic status, history of prior flu vaccine or higher COVID risk perception, and higher VE and strong healthcare provider recommendations. Next slide. So this slide combines data from 26 surveys showing the proportion reporting positive vaccine intentions by month of data collection, with the bubbles proportional to the survey sample size. Vaccine intent has declined since the initial surveys in the spring. However, surveys conducted in November appear to rebound slightly with higher acceptance. Next slide. This chart shows 6 surveys that provided COVID-19 vaccine acceptance by race and ethnicity. Vaccine acceptance was lowest among Black respondents. Some surveys showed lower acceptance in Hispanic respondents compared to white respondents, and Asian respondents reported the highest acceptability. Next slide. Common reasons for not planning to receive a COVID-19 vaccine include concern for side effects, uncertainty of vaccine efficacy, and low risk perception of COVID or severe disease. A high VE was preferred, and for many focus groups, most were open to receiving the vaccine, but many preferred not to be first. Many reported concerns that the vaccine approval process was fast. Limitations for these surveys include that they were conducted prior to an available vaccine or any specific data about the vaccines. Also, convenient samples for surveys or focus groups may not be representative of the entire US population. Next slide. So broadly, across national surveys, many adults reported intentions to receive a COVID-19 vaccine with a desire to protect themselves and their community and return to normal, but concerns were raised around side effects, unknown efficacy, and the speed of the process. And intentions varied substantially by race or ethnicity and socioeconomic status. Next slide. The workgroup also discussed several strategies to consider for overcoming barriers to vaccine acceptance listed here. This included engaging trusted sources, developing communication materials that are culturally appropriate, ensure providers have information on vaccines and vaccine recommendations, education throughout specific communities and jurisdictions, and educating non-clinical staff around the benefits of vaccine as well. Next slide. So the workgroup interpretation for the first question, does the population feel that the desirable effects are large relative to the undesirable effects? The plurality of the workgroup felt that the answer to that was probably yes, but also that it varied. It varied by vaccine, by population, and over time. Next slide. So not surprisingly then, when asked if there was important uncertainty about or variability in how much people value the outcomes, the workgroup felt that there was important or probably important uncertainty or variability. Next slide. So next, moving to acceptability. Next slide. The main question for this domain is COVID-19 vaccine X acceptable to key stakeholders? With other questions asking if there are key stakeholders that would not accept the distribution of benefits and harms overall and in the short term. Next slide. For this domain, we conducted a review of scientific literature, preliminary findings from CDC evaluations, COVID-19 vaccine attitudes, including a survey with state health officers, focus groups with nurses, and online surveys looking at healthcare providers. We also looked at broader stakeholders, including professional societies and workers' unions, and we looked at stakeholder opinions regarding programmatic, financial, and ethical aspects. Next slide. There are no published provider knowledge, attitudes, and practices surveys. State health officers voiced concerns with vaccine hesitancy, safety, and communications. 7 different focus groups with nurses demonstrated that most supported prioritizing nurses, but some were reluctant to get vaccinated, especially nurses belonging to racial or ethnic minority groups. Another vaccine survey among healthcare personnel showed that 63% reported that they would get the vaccine once available. Information from the nurses survey demonstrate moderate acceptability of COVID vaccines, where 63% were confident that the vaccine would be safe and effective, but only 34% would voluntarily receive the vaccine. Next slide. Overall, all jurisdictions have submitted vaccine implementation plans demonstrating at least some level of acceptance with the vaccine. Large and small pharmacy chains are participating in COVID-19 vaccine programs. And state health officers had concern around hesitancy, safety, and communications. And nurses reported a low percent to receive the vaccine. Next slide. So the workgroup overall felt that a COVID-19 vaccine X was probably acceptable to key stakeholders, but again, it varies among the stakeholders. Next slide. And finally, to feasibility. Next slide. So the question associated with this domain is COVID-19 vaccine X feasible to implement? Including, is the program sustainable? Are there barriers likely to limit feasibility of implementing COVID vaccine X? And is access an important concern? Next slide. So the work group discussed several barriers to implementation, including financial barriers, complexity of recommendations, access to healthcare or vaccine providers, and vaccine storage and handling requirements. Next slide. For financial barriers, as it has been discussed earlier, COVID vaccines will be provided free of charge. However, health systems or health departments could incur the cost for vaccine implementations in clinic. Next slide. Multiple vaccines under EUAs could make overall COVID vaccine recommendations complex. Individual vaccine recommendations may contribute to complexity, including variations in the number of doses or the vaccine schedules. Next slide. Population access to healthcare or vaccine providers could be limited in rural or other hard-to-reach areas. The range of providers providing a vaccine could be impacted by cold chain storage requirements, populations with proven safety or efficacy, and populations recommended to receive the vaccine. Next slide. Vaccines with ultra-cold requirements will be unable to be integrated into individual provider practices. However, vaccines with refrigerator temperature requirements will be easier to integrate. Also, a large minimum size of orders could be a barrier to implementation. And in many populations, requirements for a 2-dose series will be difficult. Next slide. However, the work group discussed that while these barriers to implementation might be insurmountable in traditional circumstances, there are innovative solutions to overcome these barriers, including expanding funding opportunities, pharmacy partnerships, technology, including second dose reminders, unique packing containers to maintain ultra-cold temperatures without a freezer, and detailed state microplanning. Next slide. Taking these barriers and the novel solutions into account, the work group felt that COVID-19 Vaccine X is probably feasible to implement. Next slide. Next slide. So this slide shows the EtR domains discussed in this presentation, as well as the work group judgments. Next slide. This slide shows all the EtR domains discussed today. It's worth noting that many of the aspects where the work group didn't reach a singular conclusion will be informed by specific vaccine characteristics or data in the weeks to follow. Next slide. So before we get into discussions around the specific EtR domains, we wanted to let ACIP know that the work group is also working our way through various proposed clinical considerations before there are any specific vaccine recommendations. As was discussed at the last ACIP meeting, pregnancy and breastfeeding was felt to not be a contraindication to receiving a COVID-19 vaccine if individuals were otherwise recommended to receive a vaccine in early allocation phases. Regarding prior infection, again as was discussed at the last ACIP meeting, vaccination is recommended regardless of prior infection, and testing for antibodies is not recommended prior to vaccination. However, while vaccine supplies are constrained, the work group discussed that vaccination of persons with recent prior infection may be delayed. However, the duration of protection after infection is unknown. Other topics have been or will be discussed by the work group for future presentations to ACIP, including co-administration with other vaccines, vaccine doses, schedules, and intervals, and the impact of vaccine reactogenicity for healthcare providers. These topics will not all require a specific ACIP vote, but would be included as interim clinical guidance. Next slide. So moving to the questions, we wanted to receive input from ACIP on each individual domain, values, acceptability, and feasibility. So we'll start with values. What does ACIP think about the values of the target population? And is there any additional information regarding the values domain that ACIP needs to see before a vote? Thank you.
Thank you very much for another wonderful presentation. I will open it up to the voting members for any comments, suggestions. Dr. Szilagyi, please.
Yes, thank you again for a wonderful presentation. I just had a couple of points I'd like to make. Some of this was made earlier. I actually view these data about values in a very positive way. It could have been much lower. The fact that there has been a decline in intention also means to me that it's mutable or modifiable. And over time, this may go up. Another point about the values is if you look at the concerns about the population that appear hesitant about a COVID vaccine, it tends to be a lot about the safety and the unknown safety of the vaccine. And we're going to be hearing a lot of information about the specific vaccines and the safety profile. So I think that might end up attenuating some of these concerns. And then there are some special concerns that we don't hear about from other vaccines, particularly the speed of the approval process and trust. And I think as organizations like ACIP and their state organizations, certainly the FDA, as the deliberations and the evidence comes out about safety of the vaccine, if that's the case, I think this may also be a mutable issue. And then finally, I just want to reemphasize the point in terms of feasibility, that to reemphasize the point about the need for not only vaccines at no cost, but serious resources at the local level to be able to deliver the vaccines, the second doses, and all of what it takes to deliver a massive vaccination program. Thank you.
Are there any comments to Dr. Szilagyi? Dr. Romero, we can't hear you if you're speaking, but in the meantime, we'll move to Dr. Paling.
This is Kathy Paling, and I wanted to concur with Dr. Szilagyi and say that I agree with the working group that the values will be very dependent. We'll do need information about the vaccines, and that will be very important. I also believe that as more information becomes available, as we review the safety and effectiveness by groups, that this will change. And so I'd encourage us to continue to follow this because it's very important for us to be able to do equitable implementation. Thank you.
Thank you for those comments. Anyone else wish to add to that? Ms. McNally.
Thank you. I wanted to commend the group on this work. This has been a very clear presentation, particularly from the consumer perspective. I echo my colleagues' sentiments regarding the additional information that we would need, but I really did want to note that on slide 12, with respect to values, that I agree with these strategies that we have here to overcome the barriers, and that I also believe that the barriers are modifiable. Thank you.
Any comments to dovetail those? All right. Dr. Hayes.
Hi, Carol Hayes with the American College of Nurse Midwives. I understand that we have not included pregnant women in any of the clinical trials for this particular series of vaccines, but I'm curious if any one could give me any information on whether or not we have data on previous messenger RNA vaccines that have been used in pregnant women. It's my understanding that we've never done that before. So could someone enlighten me?
This is Dr. Oliver. So we went into a little bit of detail at the last meeting, and so happy to provide the slides there. But the answer is correct. There have not been prior mRNA vaccines licensed, and so there have not been prior mRNA vaccines studied in pregnant women.
Thank you.
Dr. Freihofer.
Sandra Freihofer, American Medical Association. I just want to echo Dr. Slangi's emphasis on the importance of getting more resources on the local level. I mean, we put billions of dollars into Operation Warp Speed to have these vaccines available, but they don't do anybody any good if we don't get them into the arms of our patients. I also want to echo some of the other comments of the importance of trust and transparency. And I do think we're really making some headway on that. I greatly appreciate Moderna and Pfizer putting their protocols online for us to look at. I greatly appreciate the FDA putting guidelines online about what it would require before it would consider emergency use authorization. As far as safety is concerned, I mean, the press releases say they're safe, but patients really have got to know what to expect. Most of these vaccines, as has been previously said, are going to be 2 doses. And as a practicing physician, I've got to make sure that my patients will come back for that second dose. And so I think we have a good head start in hearing what these vaccine efficacies are. But we really need to make patients aware of that this is not going to be a walk in the park. I mean, they're going to know they had a vaccine. They're probably not going to feel wonderful, but they've got to come back for that second dose. So thank you.
Thank you for those comments. Does anyone else wish to add to her comments? None I can hear. Dr. Hunter, please.
Hi, Paul Hunter from Wisconsin. I really appreciate the outlining of the values and the variety of people's values, that they vary and that they're mutable and might change. And dovetailing on what Dr. Freihofer just said, I think we're going to be the people who highly value getting the vaccine soon and fast, early, are going to be really helpful to everyone else. And I think we're going to need to honor them, because they're going to let us know how it feels, and hopefully proudly state that they've been vaccinated, and help with the confidence of the people who come behind them. And I think these people are likely to be healthcare workers who are up for that kind of task. To step forward and describe what it feels like, and how they feel about taking on the role of protecting people in society. And so I think that it's just interesting to think of those people and what they value, and how they're going to help people behind them in line to get the vaccine. So I just wanted to sort of proactively honor those people. Thank you.
Thank you, Dr. Hunter. Anyone else wish to add comments? Dr. Stinchfield, I see your hand is up.
Yes, Patsy Stinchfield from NAPNAP. I want to just comment on the transparency and helping people know what to expect. We talk about reactogenicity and we use the word adverse reactions, but I think we need to speak about it in the positive. These are immune responses. And so if you feel something after vaccination, you should expect to feel that. And when you do, it's normal that you have some arm soreness or some fatigue, some body aches, and maybe even some fever. And sounds like in some of the trials, even having to stay home from work for a day. As you hear from people who are in the trials that were sort of disappointed when they didn't have any of those things, feeling like, well, I must have gotten the placebo. I'd like us to use the term more response than reaction, that this is your immune response to this vaccine, transparency, and words that I think are less scary to people.
Thank you for those comments. Anyone else? Voting members? Liaisons? I'm seeing none. Dr. Oliver, I'll turn it back over to you.
Thank you. So moving to acceptability, what does ACIP think about the acceptability of COVID-19 vaccines from stakeholders, specifically providers, health departments, and health systems? And can ACIP members or liaison organizations provide additional insight into the acceptability of stakeholders? Thanks.
Open for discussion or comment. Dr. Talbot. Dr. Talbot?
Helps when you get unmuted. So I think it would be very interesting as we think about the issues of equity for us to change our idea of stakeholders. And it may be companies and employers who we may need to work with to provide vaccine to everyone. And so I think it would be interesting, if possible, to have some idea of the acceptability of different industries that are outside the healthcare system.
Thank you. Any comments be added? Okay. Anyone else from the voting members wish to add comment? Anyone from the liaisons?
Dr. Romero, this is Amanda Cohn. I just wanted to tell liaisons and members that if they don't have any comments about additional insights at this time, they can also email to ACIP to let us know if the liaisons have additional comments.
Very good. Thank you. All right. I'm not seeing anything else. Dr. Oliver, back to you, please.
Thanks. Next slide. So for feasibility, what does ACIP think about the feasibility of implementation? And is there any additional information that ACIP needs to see regarding feasibility prior to a vote? Thanks.
So while other members are making a comment, I believe there was the section on financial cost of the vaccine, and that it was covered by the federal government. And while this is part of the issue, I think it's also needs to be borne in mind that it's a time off from work for those individuals that are hourly salaried or paid only if they work, and their ability to leave work to receive this vaccine, and the time that they may have side effects and not be able to return to work because the side effects are significant, vaccine-related side effects. So that certainly needs to be taken into account. And I don't know how you would do that, and what information you could bring to us regarding your thoughts on this. Over. Dr. Atmore.
Thank you. I want to address a point that was really under the clinical considerations, but I guess falls best under feasibility. After thanking Dr. Oliver for another wonderful presentation, and that has to do with persons who have previously been infected and in fact diagnosed with a molecular test. I would agree that it would not be appropriate to screen individuals for the presence of serum antibody, but there is a substantial proportion of the population, including healthcare personnel, that we'll discuss in the prioritization part of today's presentations, who have been documented to be previously infected. And the strategy of potentially, and I would support definitely delaying vaccination of these persons who previously been infected to later in the vaccination process. And I recognize that we don't yet know how how long these persons may be protected. And so we don't really know how far down the list to potentially put them. But all of the clinical trials that are being done are assessing baseline antibody for evidence of prior infection. And at some point, and I hope that will be relatively early, we'll have information about whether these persons who had evidence of prior infection, in fact, developed a disease, and did the vaccine protect them, and even potentially did they have immune responses to them. So at the beginning, where it's a resource limited vaccine, my opinion is that we need to try and target as best we can to those that we know who are susceptible, and in an infectious disease setting, that would be persons who've not previously been infected. Over.
Thank you. Any comments? Okay. Dr. Lynn Bata, please. Ms. Bata.
Yes, I'm going to go back to, in terms of feasibility and the issues of cost, and that the fact that the vaccine will be free is a good start, but something that we've seen in relation to testing is that when clinics are providing those tests, they will charge an administration fee to clients, and that has really been a barrier to other people going in to be tested. And I just want to make sure that we have enough information about how people are going to access these vaccines and not have to pay for an office visit of $45, $55, because I think that becomes a significant barrier. Thank you.
Thank you. Any additional comments to that?
Dr. Romero, this is Amanda. Would you like for me to respond to that?
Please.
Uninsured patients, there will be several, the primary way for which healthcare providers can get reimbursed is going to be through the PrEP Act HRSA funding, and we will be clear about how providers can do that.
Thank you. Dr. Bell.
Thank you. I just wanted to tie this discussion of the feasibility domain back to a little bit about what we heard about values, and also our discussion during the equity domain discussion, and make the point that, well, what kind of vaccination program are we talking about being feasible to implement? And that if we're serious that what we're looking to implement is a vaccination program that values equity, and that does everything imaginable, including all of the various strategies that Dr. Oliver listed in her slide, in order to address hesitancy, address various complexities, and have access, really, to have equitable access, then I think we really need, as we discussed earlier, adequate funding for implementation. I would suggest that it's perhaps not feasible, given current funding, to implement the kind of vaccination program that we are all talking about. You know, I recall during H1N1, there was this recognition at a certain point that there had been a large amount of focus on vaccine manufacturer and very little attention on vaccination program implementation. And there was a recognition that we needed to look at the vaccine enterprise end to end. And I am concerned. It's fantastic, the $10 billion that the government has allocated and spent on vaccine production. But I'm really concerned that the funds are not available to implement the vaccination program the way we think it needs to be implemented. I'm very concerned what I hear from the state and local health department partners. And so this is just a very strong pitch to say that all of our recommendations here really are conditioned on adequate funding to implement this program. And I would urge the relevant authorities to allocate those funds.
Thank you, Dr. Bell. Anyone else wish to make comment on that? Okay, Dr. Lee?
Thank you, Dr. Romero. So I just want to emphasize Dr. Bell's point again, just that the investment in the implementation and delivery infrastructure needs to parallel the investment in vaccine development. Otherwise, the unbelievable sort of accomplishments that have happened over the past, 9 to 11 months will not go fully realized without having that investment there. I did want to comment on and maybe respond a little bit to some of the earlier comments, and I apologize I didn't do it in the moment, but I found many of the comments quite relevant, and I wanted to be able to at least mention a few things. So one is, we've talked a lot about, and I appreciate Patsy Stinchfield's comments about the positive of that there is an immune response in terms of reactogenicity, potentially implying that there is a robust immune response as being a good thing. I do want to make sure that when we're considering time missed from work to get the vaccine, or even due to perhaps local or systemic reactions, that we're also balancing that against the time missed from work if somebody in the household is infected. And it actually, household infection impacts everyone in that household, even if they are not directly infected, and that quarantine goes into place. And I know that that has been a potential barrier to testing for some of our essential workers, because if they have to miss 14 days of work, that's a huge amount to miss, and their livelihood might be greatly impacted by that. So I think we do have to think about the fact that the vaccine itself, while there may be some short-term work loss issues, I do think that it has to be balanced against the risk of getting infection and what that would do, again, to the entire household and not just the vaccinated individual, for example. And then the second, in thinking about the allocation issue that Dr. Atmar brought up, reinfection may be less likely in the first 3 months. So in the setting of very recently being infected, that might be a reasonable approach. But we don't know about the durability of immunity quite yet. And reinfection is possible. So in that vein, and given the uncertainty that exists, I would actually really advocate for, when we see the data from each company, to be able to see it by age group, by evidence of prior infection, and by race ethnicity in terms of efficacy and safety, I think would be incredibly helpful for the ACIP discussions in the near future. Thank you.
Thank you. Any comments to dovetail that? Hearing none. Dr. Rockwell, please.
Yes, thank you for this. I'm representing the American Academy of Family Physicians, and also I'm trying to help a large medical group facilitate prioritization and implementation of vaccinations within our site. So I think this most comes under feasibility. So assuming that stakeholders' acceptability is there with values attended to, once groups of folks get vaccinated, will there be any guidance coming from ACIP to suggest operational workflows if vaccinees have side effects or robust immune responses that include something like fever? Recommendations for, do they get then COVID tested? And then if so, when? And what would sort of protocol be to help these employees get back to work ASAP? For instance, if the majority of an ICU staff, faculty, healthcare providers, non-healthcare providers got vaccinated within a week, say, and there was a significant proportion of these folks who experienced fever as a side effect, what do we do to help keep staff available to keep working and taking care of patients?
Hi, Dr. Romero. This is Dr. Messonnier. Is it okay if I respond to this?
Of course, please do.
So, yeah, thank you very much for bringing those issues up. We're definitely tracking the need to provide clinical guidance on those issues and already have a working group working on it. And specifically the issues that you've brought up, including if somebody gets vaccinated and then has a fever the next day, what should the workup be? Do they need to be excluded from work if they work in a hospital? How to deal with if we can anticipate a high proportion of patients having mild but significant fatigue or fever, how does that impact planning at a hospital level in terms of which staff gets vaccinated which day? And finally, on my list is if staff are fully vaccinated with a more than 90% effective vaccine, we certainly think they should wear PPE, but is there a point at which they wouldn't, if they got exposed, they wouldn't need to be quarantined because we have such a high likelihood that they're protected? So these questions and others are on our list of things for which we believe we need to have clinical guidance in advance of a vaccine rolling out. I think the complication here, frankly, is that CDC always provides some level of clinical guidance around these kind of issues with the vaccine. But what's different here is typically there is a window of time after ACIP recommendations and before the vaccine hits the shelf. And in this setting, we're talking almost an instantaneous availability of the vaccine. And so we definitely need your help in anticipating what those questions are going to be. And also for some of these specific questions, I actually also believe that we really need to make sure that we have lots of stakeholder engagement, especially around these questions that are going to impact the healthcare sector. I'm sorry that was a long answer, but it really is a complicated question, and we really need to be forthright about working through these now. There's a difference between systemic reactions and local reactogenicity, and basically we need to help folks manage their way through this. So thank you for bringing it up and for letting me have the opportunity to talk about this a little bit.
Thank you for acknowledging you're thinking about this already. I appreciate it.
Thank you. Dr. Bernstein, please.
Thank you. Once again, I want to applaud Dr. Oliver's clear and succinct and excellent presentations, and of course, highlighting the COVID-19 work group's dedication and commitment to helping us address this unprecedented public health crisis. I don't know that I have anything unique or that hasn't already been said, but I do want to emphasize when we think about feasibility, I want to emphasize how important a partnership between the local, state, and federal government for appropriate implementation of a national vaccine program. And I think that emphasizing the education and communication along with the support for distribution and administration of the vaccine is critically important. And we all know that provider recommendation is key. And this is going to take an immense amount of time in clinical settings. And it's more than just distributing an EUA fact sheet about a specific vaccine. There's going to be lots of conversation, lots of shared clinical decision-making along the way. And I think it's important that this be fully supported national level on down. Thank you.
Thank you. Any additional comments from anyone on that? Very good. Dr. Goldman, please.
Thank you very much. So one of the things on a practical level that I'm seeing on the ground with a lot of my physicians is they're just not creating vaccine implementation programs for any of the vaccines. And it's really going to be critical that we work with the liaison groups, with our membership to educate them. I've given a number of vaccine lectures on the practical setup of these programs. And I was struck by the comment on the administration fee, insured versus uninsured. It's really going to take a multifaceted approach involving not only the groups, but the insurance companies, et cetera, because while the vaccine may be free as paid for by the taxpayers, many of the insurance companies are creating barriers to care for how the providers and the physicians can deliver vaccines to patients, especially in regards to seeing patients in the office, et cetera. So we're really going to need a multifaceted approach. I'll tell you from a ground level that many physicians are not doing vaccine programs as it is. So it's going to take a lot of education just to get them up to speed on implementing vaccines, let alone a pandemic response of this scale. So I'm greatly concerned about the barriers that have been created so far up till now by many factors that we're going to have to overcome before we engage our community physicians. Over.
Thank you for those comments. Anyone else wish to add to that?
Yeah, this is Patsy Stinchfield. May I speak, Dr. Romero?
Of course, please.
Yeah, thank you. So as someone who's leading a large health systems response with vaccine and antibodies at Children's Minnesota, I really appreciate Dr. Messonnier's comments, and the questions are numerous, and developing an FAQ for health systems. The private sector does not want to be the place where things slow down because the work has been so good and so fast. But the more information we have now, even the number, how many vaccines would we anticipate? If it's 100, that's a different plan than if it's 1,000. And things like, can liquid nitrogen be used? Or should we vaccinate the vaccinators first? Or the whole question about, have you had COVID before? What about last month versus last March? Those in an FAQ, I think some brief videos, and those of us out here planning for it are really leaning on what we did with H1N1. And interestingly, we were in that moment with H1N1 where, well, I don't think we're going to get it. I don't really want that. It's a new flu vaccine. And the minute that it came out and there was limited supply, then everybody wanted it. That's human nature. And so just trying to plan and prepare, and again, having 6 feet social distancing. So what kind of space do you do this in? How do you keep it cold, et cetera? Those kinds of things. We're happy private-public partnerships at local, state, and federal levels, happy to work together.
Thank you for those comments. Anyone else wish to add to that?
Yes, this is Bob Buckman from American Health Insurance Plans. Just in listening to my colleague, Dr. Goldman's concerns on the American College of Physicians, being a past board member of the ACIP, I just would provide reassurance. I don't think the health insurance industry is looking at being a barrier to the efficient administration of vaccinations. I think that one area that would be important is that there be some rationalization to administered by out-of-network providers to avoid undue profiteering and price gouging. But in the absence of that, I think you would see a very the elimination of barriers, and we want to get people vaccinated. So thank you for the presentations today.
Thank you for those comments. Go ahead.
Hi, this is Amanda Cohn. I just want to add my thanks for everyone for those comments. They're incredibly helpful as we think forward. We do have a healthcare provider toolkit that that we're working on, that we anticipate that CDC will put out likely the first week of December. A lot of that is about how to talk to healthcare providers and how to answer questions amongst healthcare providers who may be who will likely be vaccinated early in prioritization, but we will ensure that there is easy ways for healthcare providers to find FAQs and answers to some of these questions that all of you are raising today. Thank you.
Thank you, Dr. Cohn. Anything else before I move on to the next question? All right, Dr. Panley, please. I'm sorry, was there somebody else?
Yes, Dr. Romero, this is Jeff Duchin. May I make a
Yes,
comment?
of course, Dr. Dushin.
Thank you. I think this discussion has been very informative and necessary in that ACIP is very concerned about the resources available to make this vaccine implementation successful. However, I think we also need to remember that our communities don't see vaccine as a categorical program, and we need to think about this in the context of our COVID-19 response overall. Our need to continue to do some of the other mitigation measures and to support our communities who are desperately needing economic assistance now to comply with isolation and quarantine and to meet the needs of mitigation to businesses and employees who are losing income and their jobs. When we go out to talk to them, they want us to be able to talk to them holistically about how we're supporting them in coping with COVID-19 and to come to speak about vaccine without adequately meeting needs, some of these other very pressing needs, or not having the resources to do that, I think is problematic. So I think ideally to have an economic support package that both allowed us to most optimally implement our vaccination program, but also the absolutely equally important other supports that are necessary to fight COVID-19, because as we know, we're going to continue to need to do other measures even as vaccine rolls out.
Thank you very much for that comment. Anyone else wish to offer comment?
This is Sharon.
Yes, Sharon.
Thank you. I just wanted to say that I agree with Dr. Bell and extend my thanks to her for her plea for government funding for outreach into populations of disparity to be able to improve vaccine uptake. We are obviously in notable times that will go down in history with the pandemic and the ability to quickly make and provide vaccines to the public. This also could be a notable moment in history if we can successfully make these outreach efforts and be able to vaccinate individuals who are at highest risk. And I think it's very important because we're dealing with the moment, but these efforts will extend into the future and make it easier, I believe, for people to think more positively about taking vaccine and people thinking more positively about participating in research and help with the mistrust that is felt in certain populations if we make that extra effort now. And I agree, it is just so very important to be able to get out into populations that are disadvantaged and make this effort. Thank you.
Thank you. Moving on, Dr. Paling.
Thank you. I also want to say thank you to Dr. Oliver and the entire team for this presentation, and to say that my comments actually complement those of Dr. Fry and Dr. Bell earlier. We have the knowledge, the will, and the technology to implement a timely and equitable distribution of vaccines. And there is time to support and enhance distribution systems to meet this need. That will have a significant impact both in the short term and the long term with other vaccines. One of the things as we think about the great potential to have multiple vaccines and on different schedules, it does highlight the importance of an immunization registry because and to address the complexity, making sure you've got the full vaccination coverage and do all the components to successfully meet the needs that we have today. Thank you.
Thank you. Any comments to those? Very good. Dr. Fry, do you wish to say something else? Your hand is still up. I'm just making sure. Okay. Dr. Gluckman.
Sorry, I forgot to put my hand down. I made my comments earlier.
Thank you, sir. Dr. Stinchfield, your hand is still up.
Yes, I did want it up. I wanted to just add a couple of other comments to the toolkit that Dr. Cohn mentioned. And this is around the technical aspects, so that as we are having the 2 doses getting scheduled, will there be appointment scheduling software or app that comes with it, or should we develop our own, for example? Will there be temperature monitoring, or should we think about that ourselves? And the feedback mechanisms from the local, those who are vaccinating into the state registry. So some of those technical aspects would be really important. And then I just really want to underscore Dr. Duchin's comment that American protection for those who are following the public health rules, whether it's being in quarantine because of a household member or because you have stepped up to get this important vaccine and you have now a fever, those folks should not lose their jobs because of that, and would look forward to seeing some protections for those. Thanks.
Thank you. Any comments to that, please?
Dr. Romero, this is Amanda Cohn. I'll just,
yes.
Thanks. Thank you so much. We appreciate that. We, for a lot of the technical information, we strongly recommend that healthcare systems and healthcare providers reach out or connect to their local or state health department, who are really doing an amazing job working on micro plans to implement their program. If providers who are anticipating vaccinating in the future have not connected with their local or state healthcare department, I will tell you that it will happen. These departments are doing an incredibly large amount of work to identify the earliest vaccination sites, and then we'll expand in the future. So technical information will be available both on the CDC website, but for specific information, really the health department's the best place to go. Thank you.
Thank you. Dr. Freihofer.
Sandra Freihofer, American Medical Association. I just wanted to make sure everyone knew that the AMA has actually put out CPT codes for all the different COVID vaccines and administration fees. So that information is out there if people want to start looking at those and getting ready. I also want to echo Dr. Goldman's comments. As a practicing physician, I do administer vaccines in my office, and we really need to encourage community physicians to give vaccinations in their office, to get vaccinated themselves, so they can share those stories with their patients, and because it's really going to be an all hands on deck to get our entire nation immunized. Thank you.
Thank you. Any comments?
This is Dr. Cohn. I have to make one comment, Dr. Romero, before we leave. In response to all of this, before healthcare providers and doctors and nurses and anyone seeing patients in a clinical setting, even if they are not administering vaccine early in this vaccination period, we are leaning on all of you and need all of you to help support making a strong recommendation to their patients to get vaccinated when there's, at the right time, depending on prioritization. But we need those seeds to be planted early and to start having conversations with all of their patients now. Thank you.
Thank you very much. I see no further comments. Let me turn this back over to Dr. Oliver. Dr. Oliver?
Thank you. We took many notes and we're good. Thank you very much.
Thank you very much for that presentation. And we have a break until 3 o'clock. Is that correct, Dr. Cohn?
Yes, that's good. Thank you.
Okay, good. So we'll be back at 3 o'clock then.